and I'll be doing the presentation today on charge capture and coding. I will also be doing the presentation next Monday, and then Boris will be back with you on the first week in August to complete the series. Couple of housekeeping things. As normally, we keep everybody on mute. If you have a question during the presentation, please feel free to chat it in. You'll normally see your chat box on the lower right-hand corner. If you don't see your chat box, then on your upper right-hand corner, you should see a little a balloon that says chat. If you want to click on that, then your chat button will become more apparent. And please, if you'd like to chat your questions to the host and the presenter, we'll get to those questions when we're done with the presentation. By now, I'm assuming all you folks know what MCTAC is and what we're about and some of the goals that we're trying to achieve. So we'll jump past that. We normally start these presentations just with a reiteration of our definition of revenue cycle management. I think it's important that we review the components in this process, and they're really all the administrative and clinical functions that contribute to capture, management, and collection of client service revenue. It is a life cycle of the client account from creation to payment, collection, and resolution. And it's also supported by a number of additional activities necessary to ensure that all encounters are billable, meet regulatory requirements, and revenue collection is maximized. One of the things that I add to this division, this definition is not only do you bill and collect all the revenues that you're entitled to, but you also collect them in a manner that assures that you will be able to keep them upon subsequent audits. So as again, we're looking at a cycle with a number of different components to it. You'll see the middle circle has those kind of support activities that are really critical parts of this cycle: contract management, quality assurance, utilization review, credentialing, and regulatory compliance. Last week we talked about scheduling and pre-registration and point of service registration. Today we're going to talk about charge capture and coding. One of the ways that we conceptualize the revenue cycle that we believe is helpful for people is that the activities that occur, they occur in different stages. We have a set of activities around pre-registration and scheduling that occur prior to service. During the service, that you're going to have eligibility verification, collections of fees, and today we're going to talk about charge capture and coding. There's follow-up services when the client's not there, claim submission, payer follow-up, remittance processing, and then there's, of course, all the ongoing processes that are involved in revenue cycle management, including analysis, process improvement, and quality improvement. So what do we mean when we talk about charge capture and coding? Well, we really think about this as efficiently documenting the type and duration of the client encounter and transforming that into a data set necessary to support an accurate claim that maximizes allowable revenue. There's a couple of pieces in here that we like to emphasize: certainly efficiency in documenting, in capturing the information and the data sets that's necessary. But also accuracy is another important piece of this. There's a tremendous amount of cost that can go into the revenue cycle management process that would be unnecessary if we capture our claims correctly when they occur and bill them correctly during the course of the next month. I sort of think about these errors that are related to charge capture and coding. I call them silent revenue losses. Because when you think about it, if you put a claim together and you submit it and it gets denied or rejected or you have to void it, you can quantify that. You know why it was denied, you know why it was rejected, you know how many, you may know the dollar value related to that. So you're able to capture, quantify, and analyze loss related to those kinds of errors or inefficiencies in your system. But errors related to not capturing all your claims or not billing them at the level that is appropriate and allowable are really dollar values that can go unquantified and unnoticed, which makes it a particularly difficult portion of the process because sometimes you really can't see it. So it really becomes critical to go in and take a look at all the functions and structures that you have in place to assure that you're efficiently and accurately grabbing not only just the activity that occurred, but assuring that you've captured other components to it that can maximize the billing and maximize the revenue that's allowable. And we'll talk a little bit more about that as we go on. So we tried to break down the coding elements that are necessary for this process into documentation elements, and then there are some additional E&M coding requirements, and we'll go through each of these individually. The critical documentation elements are the service that was provided, the credentials of the staff that provided the service, the duration of the service, and any modifying conditions that may affect what would be billed for that service, and we'll talk more about that. There are also additional E&M coding requirements that require that you identify client type, the complexity of the visit, and diagnosis. Going into a very deep dive around E&M coding requirements and proper coding of those services is a bit outside of the scope of today's presentation in the general overview of charge capture and coding, but we will touch base briefly on each of those elements. So, as we talked about, having different components, data components that are necessary, the first is the service provided. And those services are defined by regulation. All the regulations are posted on the OMH and OASIS websites. We gave you a very explicit discussion and requirements for each of the services for each of the different modalities that you'll be billing. It's important to understand that a service could be a discrete service. It could be that you do an individual psychotherapy visit, or it could be an aggregation of services provided during the month, and services that would be necessary to bill, bill an aggregation of services for pros, where you'd have the different add-ons and you'd need to aggregate the hours in treatment, those kind of situations. So it could be a monthly billing with an aggregation of services, or it could be discrete billing. Or certainly modality specific. Each of the different treatment modalities and disabilities have their own discrete regulations and definitions of the services, and each of them will have a rate code and a CPT code attached to it. So capturing the service based upon the regulations. The other thing that we need to take consideration is our staff credentials. may determine if a service is billable to a specific payer. The classic example of this is a Medicare-eligible provider providing services to a Medicare client. You may also have private insurance contracts that require a certain staff credential based upon a certain service. And also, staff credentials are important in modifying payment amounts, particularly in the modifiers that increase your payments in clinic for physicians, psychiatrists, and nurse practitioners. Duration is obviously a key piece in properly capturing your services. And that's basically the timestamp providing the service. Many of you who have electronic medical record, your system will timestamp, or your staff will timestamp when they began the session, when they ended the session. The system will then calculate the duration. They'll review the duration against the requirements of the service to determine whether that service is billable at the code that the system that the individual has put in, or the type of service that they put in that they provided. So some services have minimum time standards. An example of that is group therapy in clinic. Some services have different rate codes based upon duration. Of course, the individual psychotherapy 30 versus 45 minutes is an example of that. And some services have different rate codes based upon aggregate time. An example is billing in 15-minute increments for psychosocial rehabilitation, billing in 15-minute blocks for crisis services. And so obviously it is critical that the duration is captured not only to determine whether the service is billable based upon the duration regulation, but also that the proper CPT or rate code is being selected, and that's particularly important in the provision of psychotherapy inside of the clinic programs. Then there's modifying conditions. If folks had been involved in the MCTAC presentation that we had over the last 3 weeks with Gwen Diamond and Rita Guido, I know that Gwen talked a lot about modifying conditions. There's a sense that agencies are not properly capturing modifying conditions. The modifying conditions, and actually there was one left off of this, are location, on-site versus on-site, particularly with the children's program, language other than English, where you needed to have a translation service or had additional costs associated with that, credentials of your provider. Again, certain services bill at a higher rate based on the modifier if the service is provided by a physician or a nurse practitioner, and certainly the time of day when the service was provided, evening and weekends being a modifier for your clinic program. So again, I think it's very important. These are maybe slight modifications to your rates, but over time they can be certainly significant revenue streams. And it's something that if your system is not configured correctly, or if you're not billing directly from your EMR system, that you're not capturing these conditional pieces accurately and in all cases, this is where you could see a significant reduction in the billing revenue based upon really not billing at the highest level that is allowable. So modifying conditions is certainly one that we should all take a very close look at and feel very comfortable that each of the conditions that we can bill a modifier are really being identified, and the modifiers are being accurately captured. And then, of course, sent along as a modifier on the actual claim that gets submitted. Talk a little bit about E&M coding, evaluation and management coding. It applies to physicians, psychiatrists, and nurse practitioners. And CPT codes are selected based upon the client type, that is whether the client is new or established, the setting of the service, either outpatient or hospital. In most of our cases, certainly it will be an outpatient claim. The level of evaluation and management service provided, that is the complexity of the visit, and diagnosis. So where we have a situation here, let me jump over real quick to show you, is that here's an example of the EM coding variables. So your selection of your proper CPT codes are selected from a range, for your new and also a range for your established. You need to select the diagnosis. So one of the things that is very important is that as you select from the range within your options, to assure that your documentation clearly supports the CPT code that you've selected. It's probably fairly easy to determine whether it's a new or an established client, where you're providing the service, and what their diagnosis is, but the level of evaluation and management, that is the complexity of the visit, becomes a critical factor that you need to take into consideration, and that your documentation really needs to support the level of evaluation and management service that were provided at that service. We look at this as a fairly high area for risk upon subsequent review or audit, where the auditor may determine that the complexity of the service, the documentation of the service did not match the complexity that was selected in the CPT code, and therefore the rate. So what we do recommend for people is that to really take have some level of secondary review. You may not need to review every single progress note, but you should have a noting standard as it relates to E&M coding. Those should be reviewed occasionally. They should certainly be reviewed if you bring a new nurse practitioner or physician in. No clinics do it different ways. Some clinics have the physician or nurse practitioner doing the coding. Some shops have coders that actually take the note and select the proper code from that. And some shops have hybrid. They have the practitioner select the code based upon the complexity, but then they review that secondarily for consistency across the providers and consistency with the standard that's necessary to support the level of care. So, like I said, we're seeing people doing this all over the map. What's very clear, though, is you need to be absolutely certain and comfortable that the level of documentation that really supports the level of CPT code that you've selected in your E&M coding. We already took a look at the example and the level of complexity and the different variables that need to be selected. So we talked a little bit about this. Really, what's the result of poor coding? Well, we certainly see that improper, inaccurate coding may result in billing less than allowable, or in some cases more than is allowable. You have a risk of disallowance when you bill for more than is allowable, and you have a risk for insufficient revenues when you bill for less than is allowable. And again, I just want to mention that the modifiers as being a key component in this. I believe that OMH in their analysis felt that clinics were significantly underutilizing the modifiers and therefore were leaving significant amounts of revenue on the table. Improper, inaccurate coding carries a significant risk of disallowance. We really talk about having strong quality assurance programs in place. You really need to assure your codes are correct and supported by clinical documentation. It's also essential that staff understand the billing rules that guide their practice in documentation. So meeting the challenge. So this is as the process goes in terms of revenue cycle management. This is really sort of the area, I think, where the rubber meets the road, where you take that clinical intervention and you turn that into a billable set of data and a billable transaction. So one of the things we certainly see in the application of charge capture and coding is that whenever possible, charge capture should be standardized behind the scenes in your electronic health record, with the system collecting the correct rate codes, CPT codes, modifier combination based upon documentation of service, duration, and provider. So as an example, your system should be able to recognize which each of your providers, what their credentials are, the documentation of the progress note inside of the system will timestamp with the beginning and end, so you'll capture the time. There should be a methodology for capturing the additional modifiers. The system should know what time of day it is that the service was provider. It could go calculate the modifiers for weekends and evenings. It should know the provider, so it can modify the charge based upon who the provider credentials was, and that all happens behind the scenes. So all you really need to end up is in terms of workflow, is to assure that your staff take those couple critical elements that are necessary to create a clean claim. Put them in the system, complete the progress notes, and have those done on a timely basis. And as I said, the EHR setup should make it easy to identify when modifiers should be applied to the basic charge. So, and EHRs make it very simple in most cases to bill out correctly and capture those charges correctly. If they're not captured through the EHR, that is, some shops have billing systems that are not incorporated into their electronic medical records. So we have to move data either from paper systems or from other billing or other documentation systems, and then move those into the applications that are doing the billing. So we believe that there really needs to be more care taken in this kind of situation, because you have multiple people touching the data. That data has to be moved from the source to a billing application. As everybody knows, the more people who touch data, the longer it takes for it to get from its point of creation to the point where it's going to be utilized. That just opens up time for errors, for lost data, and it becomes critical that your processes that you have in place are strong, are followed consistently, are followed within the timelines, and that you have a robust quality assurance program that's overlaid on these transactions to assure that you're maximizing your billing. One thing that you could do is we talk about providing a charge master to your staff. That's basically a crosswalk from the service they provided to proper billing codes. The more that people know, the more people who know about what code, what are the rules and regulations about the services, the better you're able to catch mistakes during the process. So everybody should have a basic crosswalk that says this type of service, this duration, here's the billing code, here's what we can expect to be receiving as revenue. You need an efficient way to record, verify, and accurately report services provided. That's going to be entered into the billing system. How do you get from the clinical intervention to the data set that's necessary in your billing system to submit a clean claim? What are the workflows? What are the steps that have to occur? Where is the quality control within each of those steps? You should have those clearly documented, clearly laid out, timeline should be established. Each of your staff needs to clearly understand their role in the process. The who downstream requires and is dependent upon their work being done accurately in a timely fashion and have a smooth and accurate system for moving data. And care's got to be taken to ensure that the minimum duration standards are met and that you're getting the proper CPT codes, unlike the an EHR system where you can time stamp the beginning and end. That's part of your database. It's used by your billing algorithm to determine which is the proper CPT code. When you're off system, this is an area that becomes very important, and that assuring that the CPT code that gets billed is consistent with the timestamp within the progress note. This is certainly an area that's looked at on subsequent audit of billing. And then, again, modifying conditions. I don't want to keep harping on that, but it's the easiest thing to not have captured accurately. It is an additional step in the process, and it needs to be a seamless part of that process. So actually, going through basically, charge capture and coding, they're simple data sets, they're pretty consistent. There's fairly consistent activity that occurs over time. So one of the things I did want to talk with folks a little bit more about is some of the resources that are available, not only as it relates to the regulations, but certainly the conversion to Medicaid managed care. If you're currently providing home and community-based waiver services and are going to be moving to a billing environment for those services, many of these resources are something that are going to be really invaluable for you, and I highly recommend, if you haven't looked at these resources, that you get out on the OMH website and do so. What you'll see on your screen right now is the homepage to the Office of Mental Health. It's hard to see, but on the left-hand panel, you'll see on the top is behavioral health managed care, and next to that is phase 1, phase 2. The resources that I'm going to talk about now are in the Behavioral Health Managed Care Phase 2 tab. And there are a couple pieces in there. Actually, there are a number of pieces in there will be worthwhile for you to go in and take a look at. But I'd like to highlight a couple of them that are really critical. The New York State HARP Mainstream Behavioral Health Billing and Coding Manual is something that you should pull out and take a very close look at. It really provides the billing mechanics for all the Medicaid fee-for-service billing that's going to be moving over into managed care. You should also review this in conjunction with the coding taxonomy and also the home and community-based service fee schedule and the rate tables. The second section of this manual actually gives you very detailed information regarding the OASIS services also. And throughout the document, there's numerous links to, that's provided for your convenience, links to regulations. So again, going into the OMH website, into the Behavioral Health Managed Care Phase 2, and starting off with the Mainstream Behavioral Health Billing and Code Manual. I think that's really a critical starting point for you. The other piece that you want to take a look at is the coding taxonomy. It provides a required coding construct for billing at the OMH governmental rates. As you know, that governmental rates must be used by the managed care companies for the first 24 4 months of the behavioral health carbon. So those rates are out there on the taxonomy. And the managed care companies all have to program their payment systems to accept these coding combinations, and then look through the rate table to ascertain that the correct payment amounts for the unique coding combinations are correct. And one of the takeaways we had from the presentation that Gwen did regarding billing is that as you move forward with your managed care companies, if you're finding that they have a different understanding of the coding structure that they have to accept, or the different understanding of the rates that they have to pay, or a different understanding of the authorization environment that you're going to be working in, then you can work directly with the Office of Mental Health to try to reconcile some of these issues. OMH only asks that you are very as specific as you possibly can be, specific as to what the company is, what they're saying, what the rates are, what their expectations are of you, and make sure that the plans are meeting the expectations that the Office of Mental Health and DOH and the Office of Alcoholism and Substance Abuse has laid out from them. This is the coding taxonomy. The other thing you probably, if you're going to be providing home and community-based services, you're certainly going to want to take a look at the fee schedule. This also has the required coding combinations for providers to build a plan for the provision of these services. So it's important that you go in and take a look at what the structure is that you're going to be needing to send. I know there's some standard modifiers from my read of this. Most of the standards that were set up for the existing fee-for-service billing are going to move over into the managed care, but there will be other, the structure that will be necessary for the home and community-based services will be new, and if you're going to be billing those, you really need to get in and take a look at what those are. And then, of course, there's the rate table. It shows the rate amount for each MMIS provider ID and rate code combination. So I strongly recommend, because your agency should be listed in this rate table for billing your services, your current services. My suggestion would be is that you pull that's an Excel spreadsheet, pull that up off the OMH website, take a look at your MMIS provider ID, and make sure that the breadth of services that you anticipate and expect to be there are in that document. If you find you have questions, or if you believe there's services and that should be in there, I would follow up with OMH on that. A couple simple things, that managed care companies, that they are being required to designate a billing contact per plan, and they will also be required to provide revenue cycle management workshops to address specific plan and service needs, and state and plan representatives will be present during those workshops. I do not know if any of those have begun to be scheduled yet. You may want to work with your individual plans that you expect to be working with. The plans are required to contract with any agency in which they have 5 or more clients in their plan that are being served by that agency. As you take a look at your current information and your clients and what plans they are in, you can use that to determine what plans you're going to be working with going forward. The other thing that I saw just today, actually, and it was probably released late last week, was a special Medicaid update that's specific to the transition of behavioral health billing from fee-for-service to Medicaid managed care. In that document is a number of things that I've already talked about, references to resources, the timelines on the conversion for both upstate and downstate. I strongly suggest that you take a look at that. I would guess that that Medicaid update would be posted to the eMedNY website. So I'd suggest that you take a look at that. Also, it's going to be a fair amount of redundancy in the information that you look at, but I think at the end of the day, it will be pretty critical. We do anticipate that the transition to Medicaid managed care has the potential for some to go not too smoothly. And one of the things that we're recommending to our providers and those that we're working with, it's absolutely critical that we have our shops in shape prior to the transition. Because what we don't want to do is get into a situation where we have to spend a lot of time and energy and money because we are not capturing nor submitting our claims correctly. So please take the time that's necessary to review your shop, to review the processes that you have in place, and apply your quality assurance program to ensure that at the end of the day that you can capture your claims correctly, accurately, efficiently, and completely. So actually, we've come to the end of the formal presentation portion today. I know that we were scheduled out to 1:30 to be able to take questions. So what I would like to do is pause for a couple minutes and see what come in. So we did get a couple questions that come in. So we wrote duration in the slide about coding for home and community-based services. Do they need to start and stop times or just duration? A duration is going to be an accumulation of, in home and community-based service, at least those services that I can think of off the top of my head, will be billing based upon 15-minute blocks. So I do not believe that the bill will not require that you submit when you started and when you finished, but you will need those start and end dates to be able to accurately capture the aggregate duration of the service that you've provided. So I think based upon what I believe is no, you should record the start and stop times, but those times will not be necessary or be part of a bill that you'll be submitting. Do all the modifying conditions affect the rates for home and community-based services? No, they do not. So my suggestion would be is, again, you get out to the documentation that I outlined just previously. You'll be able to see the coding, the modifiers, the rules around the services, what is required, who is required to submit it, and those will clearly lay out for you whether there are modifying conditions that will affect the home and community-based services. You mentioned additional, I'll tell you what I do, I'm reading the questions that were chatted in. You mentioned additional payments when a session is in language other than English. Does this apply only if the practitioner speaks a different language, or does it apply when an interpreter service needs to be hired to facilitate the session? That's actually a very good question, and I would hate to give you an incorrect answer. So what we'll do is we'll take that question down, and when we will have that answer for you next week. I know that it certainly is a modifier that you use when you use an interpretive service, but I'm not absolutely certain the answer to the question. They hate to give wrong information. So we'll get the answer to that question, and I'll have that available in our presentation next week. Will the E&M codes be necessary for the home and community-based services? I do not believe any of the home and community-based services will require E&M coding. I believe that you'll see those primarily in the clinics for both OASIS and mental health services. Next question, our clinic uses V71.09 no diagnosis for diagnosis code if there is not one. Insurance companies deny for this code. Is the 799.9 diagnosis deferred or acceptable code? The insurance deferred and acceptable code the insurance company will pay for. Well, I think there's really two pieces to this question. I think that what diagnosis a insurance company will accept may be different for their Medicaid managed product or for their insurance product. So I think that if it's a contract for an individual provider or an insurance company and it's in the private insurance business, then you would really have to defer to your contract and the requirements as it relates to your agreement for that private business. As it relates to Medicaid managed care and fee-for-service, I'm going to have to defer on this question also. What we'll do is we'll be able to get you the answer to that, and I'll review the answer to that next week. You said that making sure all our systems are in place are key to success. However, the state does not intend to have the IT money ready for these providers until well after the go-live date for the health community-based services in New York City. What should the providers do? Pay for the infrastructure themselves? Well, that's an interesting question, and I think that there's probably a couple of ways of approaching this. Certainly, when you're standing up billing services that you don't have in place, there's a couple of different ways of going. You can collaborate with another service provider who has more experience in this area. I know that there are third-party billing systems that will stand up a billing system and provide back-end billing supports. Those services, you can either bring those billing applications in-house, or I know that there are certainly a couple companies in New York State that are providing billing services and billing applications in a web-based environment where you would not need to build out a relatively large internal infrastructure to be able to do the billing. That's probably the simplest way to move forward. And the other option, I know that the IT monies are not going to be available. I think that you know, if there was a way of beginning to create those kind of infrastructures before the actual dollar flows, line of credit, I don't know, other kind of foundation support, any other kind of resources that are available, you probably need to be thinking about whether you can access those. It's a difficult situation. I don't have a lot of brilliant ideas about how you would move forward this, but I do think we are advising folks to take a look at cooperating with other and working more closely with other agencies who are doing this, and then take a look at some of the web-based applications that bill specifically in New York State for folks that really understand the New York State billing. It can stand up your billing structure relatively quickly and efficiently, in a lot of cases in a web-based environment. So you don't have to invest all of that internal infrastructure. Except I don't have any great answers to that, but those might be a couple ways that you may want to move forward. Next question is, one unit of time actually 15 minutes or the better part of 15 minutes? I believe I would suggest that you look at the regulations, but I think 15 minutes is 15 minutes, and 8 minutes would not be considered a sufficient amount of time. I know that some of the duration billing in home and community-based services are defined in that the billing manual that I referenced earlier. I would go in and check that and make sure that what I'm saying is true, that 15 is 15. Next question, are services based on a one-to-one relationship in the community? A significant portion of time will be spent traveling to and from individual clients' home. Is there any place for billing travel time? I know certainly within the standard billing, that the non-home and community-based service billing, there is really no way of billing for travel time in those services. I do believe, though, that there is some accommodation for that within the home and community-based services. So again, I would suggest that you go back to the billing manual that I referenced earlier, go to the home and community-based service section, and take a look at what the regulatory requirements are, what you can and cannot bill for inside of those services. I'll take a look at those documents again between now and when we talk again next week. We'll also make sure that we answer any of the other questions that I felt uncomfortable with today, giving you the wrong information. That's all the questions so far that I've seen come in today. So what I'll do is we'll take a couple minutes to wrap up, so please feel free to chat in any additional questions if you think of them. There'll certainly be an opportunity if you think of something after the fact to either chat it in next week, or before we finish, I'll show you an email address that you can forward your additional questions to. So as today we went through, which was webinar number 2, our general overview on revenue cycle management, taking a look at charge capture and coding. I will be doing the presentation again next week. That will be at noon on Monday. We will also have a full hour and a half scheduled for that to accommodate the presentation, any additional questions that come in. And as I said, Boris will be with you in the first week in August for the final presentation in this series. If in fact you do have a question that comes up, and that after today's presentation, please feel free to submit your questions ahead of time to mctac.info@nyu.edu. If you put in your subject line RCM Learning Community Questions, that will make sure that we get those questions routed to the right person. I did want to say, for those individual that submitted a series of questions during last week, the questions that were submitted were addressing in part inpatient billing. The scope of the presentation that we're doing is really just on ambulatory billing, and we're really not, don't have the expertise in-house to answer questions as it relates to inpatient billing. So we're going to have to defer on those questions. So I don't see any other questions coming in, so we're going to let